I'd like to now move on to our second speaker, who is Professor Michael Pfreundschuh, who's a Professor of Medicine and Haematology in Germany, in Saarland, and as I said, chair of the one of the large lymphoma groups, the aggressive lymphoma group in Germany, and he's going to be talking to us today about lymphoma and some of the unusual and varied presentations. Thank you.
Thank you very much, Mark, for the kind introduction. It's a great pleasure for me to be here, and for me it's a premiere. I've never spoken for such a crowd of patients, so I'm quite nervous. I was already nervous last night because I didn't know what to do, and I worked until 2:30 this morning because I was not content with my presentation. And now I will show you what I think patients should know basically about the cause of disease. And to show you where I come from, for men from Hamburg, it's always very painful if you're mixed up with Hamburg. Hamburg is the beautiful city in the north of Germany, and Hamburg is a very small city in the Saarland, and Saarland is the smallest state in Western Germany, and still one of the poorest. And it's very small, and that's a geographical map. But I hope that when you look at the lymphoma map, that the Saarland is as big as France and Germany together. And why is that so? You see here on the right our campus in Hamburg, and no, it died. I have to do it without pointer. And we have in Hamburg the study center of the German high-grade non-Hodgkin lymphoma study group. And what you can see, we have more than 400 participating institutions. We are mostly funded by the German Cancer Aid, which was funded 25, 30 years ago by our president's wife, Mildred Scheel. And it's the main charity organization which supports research in cancer. And as you can see here, it's a little bit, I would say, a Catholic study group because most of our participants come from the Catholic western part of Germany, but recently we have more participants from East Germany. So you just heard that, and that's similar in Europe as it is in Australia. The incidence of non-Hodgkin lymphomas on the one side and Hodgkin lymphomas on the other side is very similar in Western countries. So we have about 8 to 10 new non-Hodgkin patients per 100,000 per year, and with Hodgkin it's about 1/4 of that. And the big part of non-Hodgkin lymphomas, altogether they have, or they are diagnosed in the 7th decade. That means between 60 years and 70 years of age. And in Western country, the median age of diagnosis is now approaching 70 years. Why is that so? Because the life expectancy in the Western world is increasing, and with this also the incidence or the mean age of diagnosis is increasing. And lymphoma is increasing per se, not only because the age pyramid is getting higher, it's also for unknown reasons. And similar as in Australia, lymphoma is the 5th most common cancer. Where does lymphoma come from? Lymphoma is a malignant disease of lymphocytes. And lymphocytes are a form of white blood cells which are responsible for the specific immunity. And the precursor cell is developed in the bone marrow, then it goes through the circulation into the lymph nodes, and there they differentiate into T lymphocytes. They are called T lymphocytes because they mature in the thymus. And they are mostly responsible for cellular toxicity, when cells kill cancer, for example, or when cells kill other cells infected by viruses. And we distinguish the B cells from the T cells. The B cells are called B cells because they were first discovered in the bursa of birds, and we don't have this organ. The humans in our body, the bursa is now integrated in the bone marrow. So you could say it's T lymphocyte like thymic lymphocytes, or B lymphocytes like lymphocytes from the bone marrow. And when these T lymphocytes get malignant on a specific stage of their development, then we get different diseases. If it's rather early, then we have these very fast-growing T acute lymphocytic leukemia, or the T lymphoblastic leukemia. If it's more mature, when it goes malignant, then we have peripheral T non-Hodgkin lymphomas. They are rather rare, only 10% in the Western world. Much more frequent are the B lymphocytes, which develop from the B non-Hodgkin lymphomas, which develop from B lymphocytes. And if an immature B lymphocyte goes malignant, then you have a B acute lymphoblastic leukemia. If it's a little more mature, you have the B lymphoblastic non-Hodgkin lymphoma. And if it's more mature, you have the most frequent B non-Hodgkin lymphoma, that's the diffuse large B-cell lymphoma, or the DLBCL. And with Hodgkin, until 10 years ago, we didn't know which cell the Hodgkin disease came from. But nowadays we know that the typical cell, malignant cell in Hodgkin's disease is the Reed-Sternberg cell, and it's a derivative of B cells. If you have a lymph node and make a biopsy and you look at it under the microscope, then there's a totally different picture. And according to this picture, and also according to immunological parameters and markers on these cells, you can then subdivide these lymphomas into T lymphomas and B lymphomas, and the B lymphomas with all their subgroups. Why do we need a lymphoma classification? And we don't have had for a long time a globally accepted lymphoma classification. That's rather new. I think it's 15 years only. We need this classification so that we can speak the same language. Until 15 years ago, the Americans had their classification, the Europeans had their classifications, and when we compared the results of our clinical trials, this was impossible because we were dealing with different patients. So 15 years ago, we had the first WHO classification, World Health Organization classification, and it has been renewed about 8 years ago. Oops. How does it go up? Oh, yeah, here. This is not to frighten you, but this is the official classification. And we have a lot of subclassifications with respect to the B cells on the left side and the T cells on the right side. Most of them are so rare that you must be a very well-trained specialist to see one or more a year. So I will restrict my discussion to the two most frequent lymphomas, that's the follicular lymphoma and the diffuse large B-cell lymphoma. And you can see, if you look at the survival curves, depending on the subtype, the cause of the disease is totally different, and the cure rate is different. And what you see here is a survival curve, and if you ask for the median survival, then you go to 50%, and you go then to the right, and whenever it cuts the line, then you can say, here we have median survival of 10 years, and this here, this yellow one, which is quite aggressive, we would have a median survival of only 3 years. And depending on the type, and that's another reason why we need a classification, the treatment is different. This is the distribution in Europe, and I think in Australia it's very similar. The most frequent subtype is the diffuse large B-cell lymphoma, followed by the follicular lymphoma. In Asia, it's a little bit different. Follicular lymphomas are very rare in Asia, and instead of the follicular lymphoma, Asian people suffer more from T-cell lymphomas. What are the symptoms? Usually, the lymphomas develop in a lymph node. And the lymph node grows because the malignant lymphocyte, the lymphoma cell, is not controlled by the immune system anymore. Because this cell, by mutations, has learned how to escape the immune system, and it has also learned how to adapt in a new micromilieu, microenvironment. You can also have the lymph nodes, and they are often detected only late in the retroperitoneum. That means just before the spine, and you can only detect them by CT scans and MRIs and PET scans. And sometimes there are so-called extralymphatic or extranodal manifestations of lymphomas. That means they are not only in lymph nodes, but they develop or they seed in organs other than lymph nodes. And this is an example here. You see a lymphoma that has involved the tonsils. And then, not so rare, is another organ that can be involved. That's the skin. And here's an example for an infiltration by a very aggressive lymphoma, a lymphoblastic lymphoma. And T lymphocytes have a tendency to seed in the skin, and most cutaneous lymphomas are T-cell lymphomas. And in Germany and in Europe, the T-cell lymphomas, because they manifest themselves quite often in the skin, they are treated by the dermatologist. Here, that's a T-cell lymphoma before the treatment, and then after treatment, the malignant cells die and they undergo necrosis. And other organs that can be involved by lymphomas are, for example, the lung, and I hope you see the white shadows in the lungs. This is involvement by lymphoma. This was before the patient underwent high-dose chemotherapy and stem cell transplantation. And on the right, you see that these lumps have disappeared and the lungs are clear after high-dose chemotherapy and stem cell transplantation. There are symptoms which are typical for lymphoma, even though they do not occur in every patient. And very typical symptoms, which we call the B symptoms, are fever for unknown reasons, night sweats, and weight loss more than 10% during the last 10 months. These B symptoms are much more frequent in Hodgkin's disease than they are in non-Hodgkin lymphoma. If you have the suspicion that you have a lymphoma, or a physician has the suspicion that the patient has lymphoma, the diagnostic is quite straightforward, and it should be done at least within 2 weeks. Everything that's longer, I think, is not acceptable, at least not in a country like Germany, where the density of the population is very high, and the next doctor is not far. Of course, that's a totally different story in Australia. So what has the doctor to know before he can decide what to do with the patient? Of course, he must make a thorough medical history, asking for the symptoms, asking for how long have you seen the increased lymph node. Did it grow fast? Did it grow slow? Then, of course, he must make a thorough physical examination, looking for all the areas that could be involved by lymphoma. There's a battery of laboratory tests, not too many that we need, and they have just been mentioned by Jason. And the standard imaging technique, which is now available for most lymphomas, is the PET-CT, the positron emission tomography in combination with a CT scan. And this has become the standard for diffuse large B-cell lymphoma, but also for the follicular lymphomas. And it has substituted the CT scans and the NMR. And in a recent modification of the international recommendations for the diagnosis of lymphoma, it is highly recommended that you do a PET-CT before you start the treatment of the patient, and that you skip the CT scans and the NMR. In some lymphomas, you need additional diagnostic measures like a bone marrow biopsy, and very rarely you do a spinal tap to exclude that the lymphoma has spread to the brain. I don't want to go into details, and with respect to the B-cell lymphomas, it's rather easy. The standard treatment for this patient is chemotherapy, mostly combination chemotherapy, and for the combinations we often use acronyms. CHOP stands for cyclophosphamide, hydroxydoxorubicin, O, oncovine or vincristine, and P, photoprednisone. And nowadays we combine this immunotherapy with this chemotherapy with an immunotherapy in form of a monoclonal antibody. And the first monoclonal antibody which ever made it to the clinic was an antibody against lymphomas, against B-cell lymphomas, against the CD20 molecule on the surface of the B-cell lymphomas. It's called MabThera, the generic name rituximab. And for all the B-cell lymphomas, it's a combination of the antibody and the chemotherapy, which is standard. And the monoclonal antibody, which became available nearly 20 years ago, has really changed the world of B-cell lymphomas. How does it work? You see the antibody, that's the orange one. You can develop it genetically and recombinant in vitro, and you have it then, and you give it to the patient and via infusion, and the antibody finds its way to the lymphoma cell. Because on the lymphoma cell there's the CD20 molecule which attracts this antibody. And once the antibody is on the surface of the lymphoma cell in the middle, with his back he can attract natural killer cells and K cells and bring the natural killer cells in close contact to the tumor cells, and these natural killer cells then kill the lymphoma cell. That's one mechanism. At the same time, this antibody can attract complement. These are proteins which are swimming in the plasma, and the CD20 antibody can activate these proteins, and at the end this protein will make a hole into the lymphoma cell, and the lymphoma cell will die. And then there are other mechanisms which are not so well understood. Oh, here we have the problem. It disappeared. I just wanted to show you with this curve in red. This was the survival curve of patients with follicular lymphoma before we had rituximab. And in green, you can see that the survival rate has really gone up. This was for the follicular lymphomas as an example. For an indolent lymphoma, if we go to the diffuse large B-cell lymphomas, it's like in other lymphomas too, depending on how far your lymphoma has spread, depending how good you are in a performance state, you have different prognosis. And what's our philosophy is that, and that also holds true for the indolent lymphoma, if you have a bad prognosis, if your survival curve is low, then we try to be more effective, more aggressive. If you are doing very well, like in the red curve, and have a good prognosis, then we are already at a stage with diffuse large B-cell lymphomas where we can cut back on the intensity of our treatment. So the approach, even though it's not that personalized medicine per se, we really try to give each patient the best way of chemoimmunotherapy that we have available for him. And what have we achieved? This is the progress in young patients with diffuse large B-cell lymphoma who have a good prognosis. And before the antibody became available, CHOP, the standard chemotherapy, was first published in 1975. But until 2001, there was no improvement. That means for 25 years, there was no progress, and patients were as disappointed as were doctors. And then we started a different modification of CHOP. We added etoposide, another cytotoxic drug. So we had the CHOAP regimen, and we did not give the CHOP every 3 weeks, CHOP 21, but we gave the CHOAP every 2 weeks. And you can see the red curve makes it clear that we had a significant improvement, which was the first improvement for these patients for 25 years. But then the antibody came, and you see in the blue line Now we are close to 100%. And the very good patients, young patients with a very good prognosis, they have the standard of 6 applications of the antibody together with the combination chemotherapy, and we are close to 100%. And when we are close to 100%, it's clear that we are over-treating at least some of these patients. So now, the very favorable subgroup of young patients, we are trying to cut back on the intensity. We check whether 4 cycles are enough and whether we really need 6 cycles. The most difficult population in the diffuse large B-cell lymphomas were the young high-risk patients. Patients in a bad performance status, patients with far advanced disease, and patients with, for example, elevated LDH in the serum before the treatment. And here you can see they had a cure rate of less than 50%. That's the red curve. It's below the 0.5 line. We had some improvement by dose escalation and from the R-mega-CHOEP, but with the R-CHOEP 14, that's rituximab with CHOP plus etoposide, 8 cycles every 2 weeks, we are now up to 80%. And it's very similar in the elderly population. We started with the orange line. This was CHOP every 3 weeks, what we call R-CHOP 14, and then we had available a colony-stimulating factor, the GCSF, the Nupogen, which allowed us to reduce the intervals between the 2 cycles so that the tumor did not have time enough to regrowth in between the chemotherapy cycles. And this was a big step forward. You can see the 3-year overall survival increased by 14%. And now the combination of the 2-week regimen and the antibody, that's the green line, now we are up to 80% cure rate in elderly patients. And to summarize this, we can say that aggressive B-cell lymphomas nowadays, less than 50% of the patients die who have died 15 years ago. So the rituximab story is the most successful story in oncology in the last 20 years. And indolent lymphomas, theoretically, we cannot cure them, but now with the antibodies and the chemotherapy at hand, we can give these patients a prolonged life, and not only a prolonged life, it's a life with a high quality. And even though these patients tend to relapse, there are years in between where we don't need any therapy for these patients, and now we have more than 50% of the patients with follicular lymphomas who are still alive after and without lymphoma recurrence after 10 and 12 years. So the question is somewhat academic. When do we call a disappearance of a lymphoma a cure? Is it after, in the follicular lymphoma, is it after 5 years, is it after 10 years, or is it only after 20 years? With the aggressive lymphomas, the diffuse large B-cell lymphomas, if the patients survive the first 2 years without a recurrence, then they have the same life expectancy as healthy individuals of the same age have. And the future is bright, and that's what I keep on telling patients who have a follicular lymphoma or another indolent lymphoma that does not need treatment. It's understandable that patients are nervous. They know they have a lymphoma and they want to get rid of it. But for follicular lymphomas, it's only necessary to treat them if the patients have symptoms. And to convince this patient that it's not necessary to start with treatment is sometimes very difficult. And I try to convince my patients that it's worthwhile to wait. Why is it worthwhile to wait? Because 5 years from now, our treatment for indolent lymphomas might be totally different and much better and less toxic than what we have at hand nowadays. And why is the future bright? The future is bright because we have a lot of new monoclonal antibodies, which might be as successful as rituximab has been in the last 20 years. And there's a new type of therapy, what we call targeted therapy, and these are usually small molecules, And these molecules target signals that, how we have learned, the lymphoma cells need for survival. And this is just to show you, not to make you shy, just for an example. There are pathways. These positive signals are given to the nucleus of the lymphoma cell via a chain of proteins. So one protein is activating the next protein, the overnext protein, and at the end there is a positive signal in the nucleus of the lymphoma cell, and the lymphoma cell will then produce a protein which helps this lymphoma cell to survive. And this looks very complicated, but you can see you can start with a pathway here, the CD40 molecule, or you can start with a molecule on the other molecule on the surface of the lymphoma cell, the BCR or B cell receptor. And we have now at hand a lot of small molecules which specifically block proteins which are involved in this for survival important signal transduction. And that's just a few examples. All in red are small molecules that are already available that we can use to block very important signal transductions that the B cell needs for survival. And these are the small molecules in red. And in green are the monoclonal antibodies. The monoclonal antibodies are big. They cannot make it into the nucleus of the cell. They have to act outside. But you see the green circles that we have several surface structures which can be the target of monoclonal antibodies. And you can imagine for most of the targets, there are several companies who have developed a small molecule. And to bring this into clinic, you need a trial. And because we have so many targets, I sometimes say we have more new small molecules than we have patients. And the fact that many companies have a target for the identical protein divides the patients again into several groups. So we come to clinical trials. And this is the result of a prospective study we did in the rural area of Saarland and the metropolitan area of Cologne. For 3 years, we collected all the newly diagnosed patients with lymphoma. They were registered by the pathologist to the diagnosis, and we followed them and asked the question, how many make it into clinical trials? And you can see in blue, that's extraordinary story, and I think unique in the world. A newly diagnosed patient in Germany has a 75% chance to make it into a prospective study of the German Hodgkin study group. So that's really unique, and that's the aim the other study groups in Germany are aiming at. Diffuse large B-cell lymphoma, not so bad. Nearly 1/3 of all newly diagnosed patients with diffuse large B-cell lymphoma make it into our trials. There's less follicular lymphoma, and then if you go down to multiple myeloma, it's less than 10%. Why is that so? Hodgkin patients are young. They go to the internet, inform themselves. On the internet, they find patients' advocates groups. And if these patients call the patients' advocates group, they give the recommendation, make sure that you are treated at a hospital which is participating in studies of the German Hodgkin study group. And that's why the hospitals have pressure to participate or enter their patients into the studies of the German Hodgkin study group. And it's similar with diffuse large B-cell lymphoma. So in Germany, we are quite successful because we have quite a few patients in our trials. Besides the French, we are probably the second largest trials group in the world. And that's only, in France, it's due to the structure of the medicine. It's very centralized. So every lymphoma patient has to go to a center and be diagnosed and come back with a recommendation. Otherwise, the hospital is not paid for by the state. In Germany, we have decentralized federative model of our health system. Here it's our partners, the advocates, the patients advocates group. So I showed you this to make clear that you are powerful. If the patients have a very strong advocates group, they can put pressure on the hospitals, on the private physician, that they want to be treated within prospective trials. Why do we need prospective trials? I showed you we have a plethora of new drugs, sometimes more new drugs than patients. Second, even more important reason is that progress can only be made and identified and demonstrated by prospective trials. And whenever you compare two different treatments with each other, the optimal trial is a randomized trial. And another point, the better our treatment results are, the more patients we need to even increase the cure rate. And in patient populations where we have 90%, you need thousands of patients to demonstrate further progress. So we are now at a limit where national trials are too small, and there will be more and more international cooperation. So why should a patient participate in clinical studies? In clinical studies, usually there is a standard arm, treatment arm, and an experimental arm. And the standard arm is the worldwide accepted standard. So the patient is sure that he gets the best standard known. And then he's randomized to receive either the standard or an experimental, a new type of therapy. And usually every protocol has been reviewed by an ethical committee, and the ethical committee also estimates how high is the probability that the experimental arm is better. And in the last 20 years, in the field of lymphomas, there were more than 100 prospective trials, and only one with an experimental arm that turned out to be worse than the standard arm. So you have a high chance to get a better treatment if you're randomized into the experimental arm, but you have to accept to be randomized because that's an unbiased comparison between the standard and the new treatment. And something not to forget, if your doctor treats you within a clinical trials, he is controlled by the study center. And often we notice that something is going wrong. And when we notice that in a center something is going wrong, we call the doctor, and if he cannot explain it, we go to the hospital and look why are the results worse in this hospital than the rest of Germany. And the doctors know that they have this quality control, and that's why they are with patients in a study very careful and very thorough. And last not but least, I think you give by your participation a chance for better results, which might not become available until future generation of patients. And with this, I would like to end. Thank you very much.
Well, thank you, Professor Pfreundschuh, for that extraordinary presentation and tour de force of the state of lymphoma and the importance of clinical trials, since that's the only way we're ever going to improve upon our treatment in the future. We are able to take questions, I believe. If anyone would like to ask a question of Professor Pfreundschuh or indeed Dr. Butler, please feel free to do so. It may be sometimes difficult to answer something that's highly specific to yourself, but if we can keep it relatively generic, that makes it a little bit easier. So I don't know whether anyone would like to kick off with a question. Up there, which how are we going to do that? Which one are you going to take? Easiest.
Mark, can I kick off with a question?
Of course.
Do you know how to work the microphone? Oh, and I'm very embarrassed that we don't seem to have a pointer working. Can you hear me?
Don't we?
I'd like to ask whether clinical trials in Germany, where the patients also have a 20-page informed consent document, or do your ethics committees allow you to relatively simplify?
No. I think the ethics committees can hear me.
Does it know?
The ethics committees are not so bad. The pain in the neck are the lawyers.
Yes.
And the lawyers are responsible that our information, patient information, now has close to 20 pages. And I think this is nonsense, because if you have a patient who is really sick and full of lymphoma, 80 years of age, then it's impossible that he has enough concentration to read and to understand his patient informed consent. And then there are other funny things also because of the lawyers, and partly also because of ethical review boards. In Germany we have a federal system. If we perform a nationwide study, we need to have the acceptance by 52 ethical review boards. And sometimes we have the funny thing that the ethical review board in Bavaria wants just the opposite changed in our information that the ethical review committee in North Rhine-Westphalia has. So in our current trials we have 3 patient information forms. All are 18 pages long. 1 for Bavaria, which also is something special in Germany. 1 for North Rhine-Westphalia, and the 3rd for the rest of Germany. So, of course, we must inform the patient, and we must document how long the information visit lasted, and the patient has to sign, and the witness has to sign, and the doctor has to sign that we have touched all the points that are relevant for the study and that the patient has understood it. But major problem in Germany are the 52 ethical review boards. I sometimes call them ethical mafia boards, because any change or any new protocol, we have to pay at least 2,000 euros for each ethical review board. That means before we can start a study in Germany, we have spent more than 100,000 euros to 52 ethical review boards. And we are, of course, afraid of any amendment that we have to make, because then we have to pay the 100,000 euros again.
Anyone else like to? Yes.
You talked about the fact there's a rise in incidence, and I'm wondering if that's one globally, and whether you might think that we have a rise in incidence because we have better diagnostic tools. So is the rise in incidence in the first world, and is it the same in the third world where we may not be using such good diagnostic tools like CAT scan?
I'm not an epidemiologist, but I think it's well accepted that this is the increasing incidence of lymphoma is not due to better imaging and diagnostic methods, because it's a minority of patients who are diagnosed by chance because they have an X-ray for something else. Most, I think 95% of all our patients come because they have specific symptoms or because they have noticed a lump in their neck. So that's quite, I think, quite safe to say that the incidence is true and not due to better diagnostics. The increase in lymphomas in the Western world is mostly due to the follicular lymphomas. And one theory is that we are so high in countries with a high hygiene. You say hygiene? The increase is the strongest. And one theory is that with a, let's say, too much of hygiene, young children are exposed to antigens, to proteins in the environment rather late. which can cause the immune system then not to control the immune reaction, which eventually goes to the development of a malignant cell, which then is the mother of the lymphoma. But there is no, let's say, clear-cut experimental evidence for that. Hodgkin's, for example, is a good example. Hodgkin disease is most prevalent in families with a few children. If you have only one child, the chance that the child is exposed to all the viruses, other children are exposed in the kindergarten, and it's very clear in Hodgkin's disease that families with this child has significantly increased risk of developing Hodgkin's disease. Yes, please.
Could I ask you if you could give us any information on relevant research on bendamustine?
Yeah. Bendamustine was discovered 50 years ago. I think they had the anniversary last year in East Germany. And it was one of the few cytotoxic drugs that was available in East Germany. And they used it for any malignant disease. And it worked best in lymphomas. But it also works a little bit in breast cancer, and also a little bit in lung cancer. And it survived the unification, because there was a special paragraph in the treaty between East and West Germany that the bendamustine would be licensed without further studies. And the company, the first 15 years after unification, Germany was not interested in clinical studies, but they had quite a few incentives that private oncologists would use the bendamustine. And it's no surprise that the pivotal trial, which compared the CHOP combination with bendamustine in follicular lymphoma, was done nearly exclusively by private oncologists. And private oncologists tend to cut back the dose quite easily because they are more afraid of side effects than doctors in the hospital. Because if the patient has side effect or a lethal side effect, a fatal side effect, then they are afraid that other patients might not come anymore. And what's interesting, that the curves, they made a prospective trial, randomized, with these mostly private oncologists, and bendamustine turned out to be significantly better and significantly less toxic than CHOP in the treatment of follicular lymphoma. So it's a quite attractive drug, and now it costs 500 times the price it used to cost in East Germany. And meanwhile, it has also entered, let's say, academia. And we are treating now our follicular lymphoma patients, if the protocol allows, with bendamustine and not with CHOP anymore, even though I have some concerns. Bendamustine is stem cell toxic, so I would be hesitant to give it to a patient who is a potential candidate for an autologous transplantation later on. And we regularly see that the number of stem cells that we can collect from a patient who had been treated previously with bendamustine are smaller than after CHOP. But it's an attractive drug, you don't lose your hair. And the other side effects, except for skin rashes, are less than you would experience with CHOP. It's probably not helpful in diffuse large B-cell lymphoma. The limited data that we have from diffuse large B-cell lymphoma indicates that its intervals you have to need between the one and the other application of bendamustine is too long, so that tumor has a fast-growing tumor like diffuse large B-cell lymphoma has enough time to regrow. But there are no randomized trials. And the trials in diffuse large B-cell lymphoma of bendamustine are small trials with 20 patients or even less.
With follicular lymphoma, immunotherapy is a period where you go on to the maintenance of Immunotherapy for 8 treatments or 2 years. Has there been any studies or research that having it every 2 months instead of 3 months can prolong a relapse?
No. We have a lot of information now from the pharmacokinetics, from the serum levels of rituximab in diffuse large B-cell lymphoma, but I would expect that it's not much different in follicular lymphoma. And the antibody is in the body, on the blood, for such a long time that it's probably enough to give it every 3 months. But the label is for maintenance therapy after primary treatment is every 2 months. So I think Roche is quite good at getting labels that make sure that they make their money.
But you shouldn't delay your holiday if you want to go away to Europe for 3 months.
Don't delay it.
Just on that subject, I've read some reports about maintenance predicts that after a 5-year period, there's potential that there's not much difference whether you took it or you didn't.
The Steele group, that's the German follicular non-Hodgkin lymphoma group who performed the Bendamustine trial. They have now performed a trial with Bendamustine and rituximab maintenance, where they compare 2 years of maintenance with 5 years of maintenance. But I think it will take another 3 to 4 years until we will know about the results in this study.
I was more thinking whether you take it or not in the first place, what the benefit of...
Yeah, it's the overall survival benefit at the end is not very big if you have the maintenance in follicular lymphoma only after your relapse, after you are in second complete remission, compared to the maintenance treatment that you get after the first remission. So the difference is probably not much, and there is ongoing discussion whether we really should give the maintenance treatment over 2 years, every 2 months, which is a lot of money, and if it's justified by the survival benefit, which is probably not so big. And many fans of maintenance therapy 5 or 6 years ago are now a little bit hesitant to recommend the maintenance treatment to any patients with in complete remission with first remission follicular lymphoma. In Germany, I think it's so far Germany is rich enough that any medication that gets a label from the EMA, the European Medicinal Agency, is paid for by the social insurance. But I don't know whether we can really tolerate this system in the longer future, because the new drugs are so expensive, and if every new drug is licensed and the company make their trials in very special selected patients, but then they get the label for all the patients with a certain disease, and then the results, if you go to the non-selected population, often are much worse. And this is, for many drugs which cost 10,000 euros per month, I think for society not tolerable forever. So what we really need is we need biomarkers. That means we need blood from the patient, we need tissue from the patient, and make a molecular analysis which then predicts whether it's worthwhile to give this drug to a patient, the new drug to a patient or not.
What about on a health perspective for the patient?
Is it the norm in Germany to give?
Pardon?
Is it the norm in Germany to give maintenance Rituximab?
To get?
Is it the norm to actually put patients on maintenance?
No, it's licensed. The label is 2 years, every 2 months, and so for every patient who wants it has to get it. He can sue the doctor. So if the doctor doesn't give patient something that the label that's within the label, he can sue the doctor.
I think it's fair, isn't it, to say, Mark, that most patients in Australia would get rituximab maintenance after first-line treatment of follicular lymphoma. But when my patients started, I do warn them that the caveat is that they will get that 7% increase in, the minor upper respiratory tract infections. There is a trade-off. There is a recognised toxicity of the maintenance.
And herpes zoster.
And I'm not yet convinced that there is any merit going on beyond 2 years. If your question is about, 2 versus 5, a more prolonged maintenance program.
We'll have the results of this comparison 2 to 3 years or 4 years.
Thank you.
Yes, please.
In regards to Hodgkin's lymphoma, what's the current thinking about radiation following chemo in the bulky form?
The German Hodgkin study group has had a series of prospective trials where they evaluated the radiotherapy, especially in patients. Oh, sorry. Especially with respect to bulky disease, and I was with Volker Diehl, who used to be the chairman in Cologne, and I designed with him the early trials of the German Hodgkin study group. And when we started with combined modality, chemotherapy plus radiotherapy, we gave 40 Gray, a relatively high dose, to the patients, 40 Gray of radiotherapy. And meanwhile, they are down to 20 Grays to bulky disease after chemotherapy. And the side effects, both the acute and the long-term side effects of 20 Gray radiation are very low. We have not yet gone so far not to irradiate bulky disease, that is, not to irradiate bulky disease which is larger than 2.5 centimeters after chemotherapy. If it's smaller, we make a PET, and if the PET is negative, we do not give radiotherapy anymore. If it's still positive, in the positron emission tomography, then the patients receive the radiotherapy, 20 Gray, very small dose, half as much as 10 years ago. But we don't have the data yet whether the incidence of breast carcinoma and cardiomyopathy is really going versus 0. We have to wait another 10 years. But we hope that it will be significantly less than what we observed 20 years ago with 40 Gray.
We've heard a lot about chemicals. What's the role of complementary therapies such as exercise, diet, stress reduction? Because they seem to have evidence base in, say, breast cancer. I was wondering if there's an evidence base.
There was 2 or 3 years ago, large study in lymphoma patients, that patients who are on active sports program have a better outcome. They have less relapses. Sorry. There was a large study, I think, with several thousand patients, lymphoma patients, and the result was that patients who went on an active sports program had less relapses and a better overall survival. So I heavily recommend my patients to keep active, both endurance and strength exercises. The other things are less clear. I think many reports have been flawed. So there was patients in Germany like to take zinc and selenium, but I think the evidence is rather low. What we have discovered this year, to my surprise, we had a very bad winter. We had, where I live, December, January, February, together only 50 hours of sun. So someone had the idea that all doctors had to give blood, and we measured the vitamin D levels. And the vitamin D levels, no one of our fellows had normal vitamin D levels. And we had one guy, his mother comes from Ghana, and he has a dark skin. He had a level of 3 nanograms per ml, and deficiency is below 10. So we had the idea to look at the vitamin D levels in our study. And we had serum from 365 patients. And we found that patients with vitamin D deficiency had a 12%, these were elderly patients, 12% worse overall survival. Surprisingly, only the patients who received rituximab. The patients who did not receive rituximab, there was no difference between patients with and without vitamin D deficiency. So this is very suggestive that vitamin D deficiency is interacting with the effector mechanisms of rituximab, which I described in one slide. So we asked ourselves, how can that be? And one of the major effector mechanisms is that the antibody attracts a natural killer cell to the lymphoma cell, which we call antibody-dependent or rituximab-dependent cellular cytotoxicity. So the doctors who had low vitamin D levels, we measured their natural killer cell activity and antibody-dependent cellular cytotoxicity, and then they had to swallow the tablets. And 6 weeks later, we measured the NK cell activity again, and we did this in 7 doctors, and it worked in 5 doctors. Was highly significant improvement of the natural killer cell activity. 2 doctors there wasn't. One was me. I had forgotten to take my vitamin D pills, as was the case with the other doctors. So in 5 out of 5 cases where we reached normal vitamin D levels, the natural killer cell activity was much better than before. Now, what to do with this message? A randomized trial would be the best, but that's the problem because there are clear recommendations by the German and European Societies for Gastroenterology and Nutrition that once you diagnose vitamin D deficiency in a patient, you have to substitute the patient with vitamin D. So it would be ethically highly problematic, and we would probably not get it through the ethical review board. The second thing is, once this message has spread, and I hope it stays in Australia, does not directly go to Germany, the patient will take it anyway, and we cannot force them into a randomized trial. So what we do, we have now serum from 200 patients in our latest trial, and starting with patient number 300, we will substitute each patient with vitamin D, and then we will compare the results in the first 100 patients with the results patient number 301 to 500, and then we hopefully can demonstrate that it helps, because this would really be something extraordinary. 12% improvement of 3-year overall survival, that's much more than all the new drugs are aiming at. But in Australia, you don't need so much. Sorry. Yeah. I'm not such a vitamin D expert, yeah. But I was told that 25% of the I don't know data, but I was told by who was the doctor from Adelaide? He told me that 25% of the Australian patients also have vitamin D deficiency, despite the sun. So I would recommend to measure vitamin D levels when you diagnose a patient with lymphoma. And if he is treated with rituximab, I would substitute it and normalize it, because it's cheaper and has no side effects.
Are you familiar with coenzyme Q10? Are there any benefits in taking that?
Not that I know of. Yeah.
You make very expensive urine.
Yeah. And in Germany it's not as bad, but in Switzerland there are a lot of very expensive private hospitals where these patients go to. And I always, if they ask me what I think about it, I say go to church and take the water, make the cross. It helps at least as much.
Yeah. Michael, Myron?
I'm asking you something. Is there any evidence to suggest any correlation between sugar and the increase of tumour activity in the body. Because what interested me when I was going through mine, and the PET scan happens to be a radioactive glucose in which the cells stick to, and the little research I did, I was wondering if there's any correlation.
Theoretically and in vitro, yes, because tumor cells are much more able to use the glucose by glycolysis than normal cells. And the question is, and it's very likely that's the new field of metabolics, that we can influence the growth of the tumor by giving certain things in the food, but theoretically that's possible. In normal life it's very difficult not to give any nutrition without glucose. So it has become a recent interesting field, so-called metabolomics, and I think it will become more important in the next couple of years, and I think there's still some interesting discoveries to make with the nutrition and the relationship between the way how we eat and drink and tumor growth and tumor cure. But so far, the clinical epidemiological data is very, very soft.
Okay, so thank you so much. I think we should thank Professor Pfreundschuh. I think